You guys will have me for all of block 3 and all of block 4. So finishing up block 2, you've already had a lot of the information. I'll introduce some new drugs today, but you've talked, in depth about NSAIDs, Tylenol, all those things. So we should move it through arthritis pretty quickly. So the 3 main things we're going to discuss today is going to be OA, which you've already had some instruction on, right? And juniors, I know you've already had it in ortho, but we're in Pharm, right? So we're going to focus lectures and the testing on the Pharm, right? So we always in Pharm are going to give you the diagnosis, which is a little bit different when you get over into the ologies, where you've got these long vignettes on test questions, ultimately, like you will see on the pants, where you have to get to the diagnosis, what type of imaging, all those things, and then the Pharm. So here we're going to give you the diagnosis on the test, a little bit shorter clinical vignettes. So these 2 hours will be on your next test, and it'll be on osteoarthritis, rheumatoid arthritis, and gout is what we're going to discuss today. I will, for housekeeping, what I'm probably going to do is start after next week, which is when we begin block 3. Then I'll just do weeks in each classroom. That's probably the easiest thing to do, is to do a week in one classroom and then switch. And then obviously you guys are already familiar with, that'll be Zoom when I'm over in the other classroom. So hopefully technology works for us and we don't have any issues with that, but we will get through it. So without any further ado, arthritis. I like to, on all my lectures, I usually put the meds discussed as the first slide, just as not for you to go memorize. This is when you're studying, you can go back and kind of quickly reacquaint yourself and figure out where you're at. Like, what class is this medication? But use it as a study guide. Do not memorize it unless that's just your jam. Then by all means, go ahead. So these are our learning objectives. Basically, we're going to tell you the diagnosis, gout, rheumatoid, or osteo, and then you're going to discuss, you'll be able to pull out the Pharm for that. All the same things we've talked about, right? The indications, contraindications, drug-on-drug interactions, precautions, those type things. So before we get started, we're just going to check, what do you know already, right? You've had some familiarity. Are you going to know the answer to these? Some yes, some no. But by the end of the lecture, hopefully so. So what's a topical NSAID used for hand and knee OA? Voltaren gel, what's the, that's the brand name. What is the generic? Diclofenac gel, right? Good. So NSAIDs help with pain and arthritis disease control. No, right? No. What are NSAIDs going to do? Pain and inflammation. They are not going to control OA. They're not going to stop the progression of OA. Important concept when we talk about OA versus rheumatoid versus gout. We're going to be using NSAIDs in all 3. Right? But they have a different utilization for each disease process. And then how soon could colchicine be used for gout flares? Probably not many of you know the answer to that, but by the end of the lecture, you'll know within 36 hours to utilize that drug for it to be effective. So what is the role of DMARDs in RA? DMARDs, disease-modifying anti-rheumatic drugs. Well, here's a clue. It's in the name. It's disease-modifying. It can actually slow the progression of rheumatoid arthritis and joint damage. Unlike what we just said about NSAIDs and OA, pain and inflammation do not modify the disease. True or false? Tylenol, first line for OA. Tricky, right? Because it used to be, yes, Tylenol first line for OA. But more recently, the guidelines are use an NSAID, but if you can't, okay, we can use some Tylenol. Obviously, Tylenol comes with risk, so we're going to discuss that further. But it's historically was recommended, but the American College of Rheumatology now say, if we can, let's use NSAIDs. If not, then we're going to try acetaminophen. So it's conditionally recommended. And then lastly, what's the serum urate target for gout? So 6 milligrams per deciliter, and you're gonna get that as we move through the lecture. Sometimes we say 5 if there's TOFI present, but I'll bring that up when we get to it. Start with OA. So most common form, basically degenerative breakdown of the joint cartilage. Causes pain and stiffness, and you'll often hear patients say, hey, it gets better with movement, and then when I rest, it stiffens up again, right? So it's chronic. Usually that pain and stiffness, hands, spine, lower weight bearing joints. Obviously it's going to be a huge percent of the patients that are coming in the services, right? You're going to see OA every day, knees and backs, for sure. And then we have RA, rheumatoid, systemic, symmetric, autoimmune, very different. So you'll hear people often say, oh, arthritis. Well, you've got to differentiate that into OA versus RA. One is a chronic breakdown, right? Wear and tear, OA. Rheumatoid, systemic, symmetric, autoimmune disease, swelling, pain, inflammation, usually symmetric being, both bilaterally. Hands, wrists, and feet is where you're going to see it show up. Quick note on the pathophys of osteo. Chronic degenerative cartilage breakdown, pain, loss of joint movement, mainly in the hands, weight-bearing joint, knees, hips, feet, and spine. So we give lifestyle modifications, we control the pain and inflammation, and hopefully keep the patient from progressing to have a total joint replacement, right? So how do we treat OA? Lifestyle modification is huge here, right? We have to educate our patients. We have to relieve their pain and stiffness. We have to teach them through usually PT or OT, improving their joint mobility, to limit their functional impairment, and to maintain or improve their quality of life. So basically, OA management is aimed at improving quality of life and decreasing pain, right? Cornerstone being that non-pharmacological treatment. Weight loss is going to help weight-bearing joints. Exercise, PT, OT, because exercise is hugely important to strengthen the muscles surrounding that joint. And then for pharmacological therapy, as we mentioned, it's going to be aimed at pain relief only. We cannot modify disease progression. There's not a medication to slow down the joint destruction from wear and tear in OA. So what are we going to use? Tylenol, as we mentioned, conditional recommendation if folks can't take NSAIDs. NSAIDs, both oral and topical, which I think you've discussed already with your teach-ins on pain over this week or last week. We can also talk about putting a steroid into the joint to decrease pain and inflammation, i.e. an intra-articular corticosteroid, which you're going to get more in-depth knowledge on that when you get into ortho junior semester. And then we'll talk about tramadol, Ultram. So it's conditionally recommended for folks when NSAIDs are contraindicated or they're not working, but however, it comes with lots of risks. So that's why it's in red, and we're going to discuss how some recent studies show it's no better than a placebo. So for OA, right? So if it's no better than a placebo and there's a whole bunch of horrible side effects, which we'll talk about, then have to approach tramadol with caution. So here's a table summarizing the 2019 Arthritis Foundation OA guidelines. So basically they're stratified in the chart by the affected joint, whether it be hand, knee, or hip. And then you can see the recommendations, non-pharmacological, obviously strong. I told you it's a cornerstone for OA. And then there's some of the treatment, weight loss, self-management programs, exercise, PT, OT. Pharmacological approaches, a little further down, that are strongly recommended by the ACR are going to be the oral NSAIDs for hand, and then knee, you see the list there, and then hip. We're going to talk about kind of these as we move forward, but this is a good reference chart. And then conditional recommendations, you see down there, tramadol, right? And then also duloxetine, so an SNRI is recommended for chronic pain. You'll see it sometimes prescribed for folks with fibromyalgia, but also in OA, it's a conditional recommended drug. So duloxetine's SNRI. Topical capsaicin there, you'll see for the knee. Did y'all talk about that with pain? Right? And she talked about be careful if folks are having it on their hands. Arthritis, rubbing the eyes might not be such a good thing, or touching numerous other parts of your body with hands with hot pepper on them may not be a good thing. So this is a good reference chart to look back at. Notice though, the ACR says for the hand OA that topical or conditionally recommended. PANTS and PAEA say that is recommended, so that's one little derivative we'll talk about. Like for the hand, we do recommend it, especially for older folks or folks that have some kind of chronic issues, especially like kidney disease, right? We don't want as many systemic effects from an oral NSAID. So topical, knee and hand usually, and we'll talk about the specific agents. And I think you already have, so it will probably be a review of the specific agents. So acetaminophen, not fully understood as far as mechanism of action, may inhibit nitric oxide pathway. So it's a central, it acts centrally. It's an analgesic and an antipyretic, right? So it helps with pain and it helps control fever. It does not have a significant anti-inflammatory effect or antiplatelet effect, unlike NSAIDs, which are anti-inflammatory, thus in the name. So it acts centrally. We use it for mild OA pain. It's conditionally recommended by the last chart, right? So less pain relief than NSAIDs, but it does have the positive benefit of less drug reactions. PANTS and PAEA say only if NSAIDs are contraindicated for OA do we move to Tylenol as our first line. But what do we have to be careful of? Liver toxicity. So folks with liver disease, no Tylenol. Alcoholics, avoid Tylenol. So now we move into the NSAIDs. Broad class, right? Y'all have had them. I won't want to kick this dead horse again because I think you talked about them at length, and not only in Pharm, but other courses. So you know the difference between the COX-1s and the COX-2s, right? The COX-1 inhibitors, usually your broad ones are going to inhibit COX-1 and COX-2, but if we have GI risk, right? GI bleeds, because when NSAIDs inhibit that COX-1 pathway, it gets rid of our protective prostaglandins on the gut lining, right? So we can have gastritis, or we can have GI bleeds, or inflammation, gastropathy of the stomach. So obviously when we have patients that have those type issues in the GI tract, then we want to select more likely the COX-2s, the Mobic or the Celebrex, right? So that we can decrease the risk of GI issues, but the trade-off is that the COX-2s have a higher rate of what? Cardiovascular risk. Good. And then for the NSAIDs, usually recommended, but topical if it's our older patients, or as I mentioned, if we have those kidney disease. Not disease modifying. Do not combine multiple NSAIDs to try to get better pain relief or increase of inflammatory blocking. Combining more NSAIDs is only going to increase your risk, whether it's cardiovascular or GI, based on which which specific NSAID you're using. So don't combine NSAIDs, right? Do not use it in patients, as I mentioned, with peptic ulcer disease, renal or kidney issues, or any bleeding disorders, or active gastro issues. Aspirin, not your first line choice for NSAIDs, because as you've learned in other classes, it irreversibly binds to those COX-1 and COX-2 enzymes, unlike the other NSAIDs. So not using aspirin as our NSAID as first line for OA. Topicals. How do we use it? Knee and hand. There's no long-term efficacy in the data for it, but we do say it's useful in patients greater than 75, or they have that cardiovascular disease, or anyone who shouldn't use systemic NSAIDs, i.e. kidney issues. Voltaren is the only FDA approved, as a couple of you pointed out in the pre-check on knowledge. So it's the only one approved for hand and knee. The one below it, the Pinsed, the solution, is approved for only knee. But first line for the topicals, you'll usually see it, diclofenac gel, not the solution. So the Voltaren. Applied 4 times a day. I'm not going to test you on the dosage, but it's applied 4 times a day, and on the bottom right, you'll see that little card that comes with it basically is showing you how much to use, right? So you don't use too much of the NSAID. Although it's less likely to cause systemic effects than oral, it still can, right? It still can. So we don't want to start putting, giant gobs of a topical gel all over our body and think, oh, well, it's good everywhere, because yes, it is systemically absorbed, but obviously not as much as oral NSAIDs. But there is a limit, so it comes with the card. Black box warning, even though it's topical. So the black box warning is the CV and thrombotic events and the GI bleeds. You can get other NSAIDs in a compounding pharmacy. This is more an FYI, right? You can get a compounding pharmacy to make some topicals out of ketoprofen, ibuprofen, indomethacin, but the diclofenac gel is the one that's FDA approved, coming out off the shelf, right? Now we talk a little bit about the intra-articular corticosteroids, i.e. putting a steroid into the joint that is having the issue, the one that's having the cartilage breakdown. Typically, triamcinolone, methylprednisone is what we're going to use. Often, it says on the slide may combined. I would say often we're going to use some lidocaine with it for the anesthetic effect, reduces the pain of the injection. So we've already talked, I'm sure, in numerous classes about what steroids do, so I won't get into that, but yeah, decreasing the inflammation that's caused by that breakdown of the cartilage in OA. So how do we use it? Short-term symptom relief within a day to 3, peaks out a little over a week, 7 to 10 days, lasts 4 to 8 weeks. We recommend no more than 3 to 4 injections in a single joint per year. Why? Because those steroids, although they can decrease the pain and inflammation short term, if you're using it chronically, you can get systemic effects from chronic glucocorticosteroids, which I'm sure y'all have discussed already, but we're going to highlight again when we talk about the orals. But you can also start to break down the cartilage even worse. So if you're having to do more than 3 to 4 times per year, or the patient is stating they need more than 3 or 4 times a year, it's not working, right? It's inadequate response to those injections. So doing more than that doing more than that frequency can cause you more harm than good. So we're going to limit it to 3 and 4 if we do an intra-articular corticosteroid, because the degradation of the cartilage is significant. Well, what's our problem to start with? Degradation of cartilage. So if we're treating degradation of cartilage too aggressively with steroids, then we're only worsening the problem. And we'll talk, hopefully a review, about systemic effects. Yes?
So I assume that's from a direct mechanism of the steroids on the cartilage, but would it also bring back more, like range of motion in the joint where they're now actively using it more, where they wouldn't have so much?
No, it's not related to the mechanics. It's not like, oh, it feels better. I mean, could there be a component of that? Like, it feels great, I'm going to run a marathon? No, it may be. But more than likely, it's the mechanism of action of the steroids effects at the joint in the cartilage, in the joint, in the synovial fluid in the cartilage. For the junior classroom, if you didn't hear the question, I forgot that questions have to go up to the mic. So the question was, is that degradation of cartilage increased with the corticosteroid injection because the joint's feeling better because you're putting so many steroids in it, so patient increases activity, so therefore it's a mechanical further breakdown in the cartilage? And you heard the answer, no, not likely. It's more likely to the direct action of the steroid and its effects on the cartilage at the site. Good? So adverse effects, like I mentioned, you can get systemic. You can have hyperglycemia, edema, elevated blood pressure, dyspepsia, and you can also, if it's real high levels, you can get adrenal gland suppression if you do too many of these injections, all of which you also get systemic effects if you take oral steroids too much. Even in low dosage, you're going to get some of these, like short duration of oral steroids can give you those first couple there, right? Hyperglycemia, edema. Is that a review for everyone? And I'll talk about the ones I want you to focus on when we get to those slides. Tramadol, again, as I said, centrally acting analgesic, dual mechanism, weak mu opioid receptor agonist, and it inhibits serotonin uptake. It is a scheduled 4 controlled substance. So the recommendations are if patients can't take the NSAIDs and they have moderate to severe OA pain, okay, we can consider it. However, this drug can lower the seizure threshold. Obviously, it is a controlled substance. We can have some addiction. So I would say avoid it. There's conditional recommendation for it, but you have the metabolism is based on the enzyme, so each person may respond a little bit differently to it. Did y'all talk about tramadol with your teaching? So this is all review, right? Did she say the same thing, that it's conditionally recommended and you know, patient specific with this one, right? Make sure I don't hit anything else on this slide. Yep, just know it's conditionally recommended with the caveat there that only with NSAIDs that are contraindicated or ineffective. So adverse effects, I already told you it lowers the seizure threshold. If you have medications that also increase serotonin levels like SSRIs, SNRIs, now you're at risk for serotonin syndrome, which we've had before, right? You know what serotonin syndrome is and those what the syndrome looks like classically. So any of those drugs, right? SSRIs, TCAs, MOIs, all those triptans for migraines, which we're going to talk about in 2 weeks, can also increase serotonin. So a lot of precautions with tramadol. So I would say use at risk. What to use, and now we'll talk about what not to use, right? Just as important as what not to do. Yes, OA can cause chronic pain, so patients often will present to you with worsening pain, lots of ADLs affected according to what joint is being affected. And so folks want to move off into that chronic opioid area and such a high risk of dependence, tolerance, because did we say that there's anything that could control the disease progression? So now you just bought, you know, possibly someone who's going to be on opioids for a long time, and that has a whole other list of problems, right? Dependence, tolerance, risk of overdose. So there's also, none of the studies really show there's long-term benefits of chronic opioids with OA. It still progresses the same if it would without them. So not recommended, and you didn't see them on those recommendations from the American College of Rheumatology. So avoid chronic opioids. Glucosamine chondroitin. So lots of folks are going to take it. I took it when I was having a lot of OA pain. However, it's not FDA approved. Why? Because it's a supplement. So I wouldn't be handing it out and charging patients for my glucosamine in my office. It's, like I said, not recommended on that American College of Rheumatology guidelines. So probably a few people in here have taken it. Some benefit, some don't. It's not regulated though, right? It's not regulated by the FDA. So you get what you get when you buy it. You don't know the manufacturer. You don't know their processes because it's considered a supplement, not a drug. Hydroxychloroquine, we're going to use it in RA, but this is like a mismatch of the mechanism. It does nothing in OA. And it has a lot of risks, especially for CV and retinal. But sometimes you'll see folks put on hydroxychloroquine for OA. It's not going to do anything for them and very significant risks. And we'll talk about what the drug does when we get to RA. Vitamin D, you'll hear people recommend it. Don't give vitamin D unless they have low levels of vitamin D and calcium, right? It's not going to do anything for their OA. And because it's a fat-soluble vitamin, you can take too much of it and get toxicity, which you'll talk about in GI, and the juniors, we talked about it earlier this semester. Moving on to RA. autoimmune, chronic inflammatory polyarthritis of the synovium. So unlike wear and tear, it's not wear and tear. Their own body is turning against itself, right? So the body's immune system, usually driven by the T cells, attacks the synovium of the joints, and so the lining of the joints are affected. So you get chronic inflammation, pain, swelling, and progressive joint destruction if you don't get after it early, right? And that's what we're going to talk about when we talk about the pharmacological approach, what meds we can use to get after early, slowing the progression of RA. So there's some key inflammatory cytokines that are involved. I only tell you this, we're not diving deep into the biochem or the micro of this or the pathophys, but because some of the medications work on these inflammatory cytokines, and that's tumor necrosis, alpha, and interleukin-1, also interleukin-6. And I say that because the tumor necrosis factor alpha and the interleukin-1s are drug classes that we're going to talk about when we start talking about the different medications that can be used. But basically, all the drugs we're going to talk about as far as when we talk about affecting the immune system in RA are somewhere in that immune inflammatory response. It just is a different marker based on which class of drugs we're using. And RA can infect the entire body. And with its action in RA, with that autoimmune response, you just have increased inflammatory mediators, the histamine, the prostaglandins, C-reactive protein, and so all of the medications we're going to talk about that are specifically slowing the progression of RA joint destruction are acting somewhere in that immune response to decrease those inflammatory markers that the autoimmune process causes. What are the goals in RA? Fundamentally different, right, than OA. First, we want to worry about disease control. And the special class of meds we're going to talk about is those disease-modifying anti-rheumatic rheumatic drugs. And then we'll talk about some newer stuff and some biological agents that can do that, which now we have drugs that can slow the joint damage versus RA, treat pain and inflammation, and get them on a healthy lifestyle and exercise. But we also treat the pain. So that's when the drugs we just talked about for RA, basically the same meds come in for pain control. Because we can treat the pain control quickly while we're getting on something to modify the disease progression, i.e. a DMARD, and we can get the pain under control while we're bridging to that DMARD, which takes longer to start having its effects on the body or on the autoimmune disease process. Same ultimate goals: improve ADLs and the quality of life. So RA, non-pharmacological, rest during acute flares. These folks can have severe flares with severe pain. PT and OT comes back into play. We can talk about if there's a severe joint destruction, some assistive devices. I mean, you can use that in OA too. You've seen people with canes, you've seen people with walkers, you've seen them in wheelchairs, some assisted devices. Weight reduction also helps in RA, just like OA. And then pharmacologically, for pain, we're going to use the NSAIDs, which are usually the first agents that are going to be prescribed for the pain. Once again, bold, right? All capitals. Well, all capitals, not bold. But it does not alter the progression. We're only treating pain with the NSAIDs. Corticosteroids we can use as a bridging therapy with the NSAIDs to get the inflammation down quickly. Usually we're talking oral here. We can do interarticular like we did for the OA, but sometimes when people are having a flare, we'll get them in some pain control with NSAIDs and also give them a short burst basically of steroids to help control the inflammation while we're waiting on those DMARDs to kick in, and we'll talk about that timeline when we get specifically into the DMARDs in the next couple of slides. DMARDs, these are your breakdown of classes. The methotrexate is kind of your go-to, baseline, and we're going to talk about why. But methotrexate usually involved in the treatment of RA. And then there's other agents, and finally the newer biologics. And all of them come with risk benefits, but we'll stratify out what those are to help kind of make decisions on which medications in the DMARD class we're going to use. all aimed at slowing that disease progression and getting it under control. And I mentioned earlier that duloxetine is FDA approved to treat chronic musculoskeletal pain, duloxetine Cymbalta, SNRI. You don't see it utilized that often, and if you look at the chart, for OA, it was conditionally recommended. So you can also use it for pain control. But if they could take NSAIDs and steroids, that's where we're going to go. Okay, so this is the 2021 guidelines for RA, same organizations that we looked at for the OA. The big thing to get from this chart is that if it's moderate or high disease, methotrexate. Right? Methotrexate is usually first line. And then we're going to talk about if methotrexate monotherapy doesn't work, then we're going to add in some medications. The take-home point here in the bottom, which is conditional recommendations, but you'll see in the green box at the bottom there, it says a combination of the conventional synthetics, which would be methotrexate and some others we're going to talk about, the conventional synthetics being a class, or we call them traditional as well, methotrexate in that class, and there's a few others. However, normally you're going to see, instead of doing 2 conventionals, because all of the recent studies are showing the efficacy of the newer medications, right? The TNF inhibitors, whether that be the TNFA alpha or the non-TNFA alpha, get them on one of those, or a biologic agent. If that doesn't work, then the newest of the new, the JAK inhibitors and methotrexate. So basically the take-home point, if you're looking at this, is although it does show you can combine the conventional synthetics, better efficacy by using methotrexate with something from the newer class. You never want to just go conventional, conventional, conventional. If methotrexate isn't doing it, go ahead and move into one of the biologic classes or the JAK inhibitor, which is not a biologic, it's a different type. And we'll talk at length on that. So this basically just summarizes what I just mentioned. You're going to treat the target with the DMARBs. You just want to get the disease activity down, right? And then either add into methotrexate a biological or a newer target-specific DMARB, and we'll show you the classifications of those. And as I mentioned, that's recommended over doing methotrexate plus the SSX and the HCQ, another 2 other conventionals, and we're coming up on a chart to show them, but not using triple therapy all from the conventional class, using methotrexate and then adding one of the biologics or a target-specific DMARB, Janus kinase inhibitors, which are not biologics. And the bottom bullet is exactly what I mentioned about using a DMARB from a different class versus staying in the same class and adding on multiple agents in the same class. And when you see the chart of them, it makes it a little more clear. So NSAIDs in RA, treatment of pain and inflammation, it's an adjunct to the DMARDs. Don't alter the disease progression, and usually takes 1 to 2 weeks of daily NSAIDs to really show its best efficacy. We already mentioned for NSAIDs, like I said, numerous times, numerous instructors, numerous different courses about avoiding NSAIDs with gastritis, peptic ulcer disease or PUD, renal disease, or any kind of bleeding disorder. So corticosteroids in RA, we already mentioned it. We can either do PO or we can do some injections. So for the PO, that's usually going to be prednisone or prednisolone. So prednisone has to be converted in the liver to prednisolone. So prednisolone is the active form. So if someone has liver disease, you can't use prednisone, you have to use the prednisolone. Also, the prednisolone comes in an oral solution or an oral disintegrating tablet. So you'll usually see the Orapred used for kiddos as well. That's just FYI, I'm not going to differentiate on your exam and about why would we use one or the other, just so that you know, and the difference between them. We can also do the IV version, methylprednisone or Medrol. We are not using corticosteroids long term. They're bridging therapies to help with the pain and inflammation. If there's an acute flare, we can use them as a burst treatment for anti-inflammatory effects, but we don't use them long term. As the 3 bullets at the bottom of the slide show, use as a bridging agent, quickly control the pain while they're getting started on their DMARD. And as I mentioned, 2 to 4 weeks, either PO or you can, if it's one single joint, you can do intra-articular burst therapy for acute flares, usually for a few weeks, or when you give that intra-articular injection, which lasts about the same time. We talked about how long it was effective in the joints. You can be on maintenance therapy in RA with severe RA, very low dose while the patient's on DMARDs, but that's severe cases because we all know the long-term sequela of chronic steroid use. Short term, I need you to know the difference between the contraindications or the adverse effects, for short-term use of corticosteroids and long-term use. So I will tell you that short-term hyperglycemia is a big thing, right? Especially if the patient's already diabetic or pre-diabetic. But make sure you can pull out, because the PANTS expects you to pull out the differences from corticosteroid use, short-term doses versus long-term or chronic use. So should be a review for you, but make sure you pay attention to those. Extensive list, but no in general. So now we move into the cornerstone of RA treatment, right? The DMARDs. They actually modify the disease process. So DMARDs, mainstay of treatment. You try to get them started, your RA patient started on a DMARD within the first 3 months of symptoms onset. You're not going to see a big change for at least a month or so, and then maybe up to 6 months. That's why we used those bridging therapies of the NSAIDs and the corticosteroids if needed to control the pain and inflammation until the DMARD kicks in. Should be used for every RA patient as a DMARD, unless it's very, very mild or limited disease. For the DMARDs, everybody gets a hepatitis B and C and a TB screening before you start them, right? Because the DMARDs, as a class, the DMARDs all lower immune response. So you got to make sure they don't have any major active infection ongoing before you can start it, because their immune system's already low with a chronic disease or an infection like hepatitis B or TB, and then you throw in the methotrexate, for example, or any of the biologics or any of the DMARDs at all, and now you're going to have decreased immune response from the body, so you just set yourself up for a major flare of that chronic disease process they already had. So 3 main classes, and I've mentioned them a little bit in the last couple of slides. So the conventional synthetics, or you'll see it abbreviated CS, is your methotrexate, also Rumitrex. That's the cornerstone, right? Methotrexate and conventional are your cornerstone. And we'll talk about the other 3 in that class as well. And then biologic DMARDs, so they're broken down into either that tumor necrosis factor alpha inhibitors or non-tumor necrosis factor alpha inhibitors. And lastly is the new one that I talked about, the Janus kinase inhibitors, the targeted synthetic DMARDs. And they are not biological. So the ones under biologics are the only biologics, right? The conventionals aren't biologicals, and the targeted synthetics are not biological agents. And we'll talk about why that matters as we move on. But as an overall class, screen for Hep B, Hep B and C, and tuberculosis, and don't start anyone with some type of active infection of any sort on a DMARD. Wait till the infection clears, or ensure they don't have chronic Hep B or C or TB. So conventional synthetic or traditional DMARDs. Methotrexate, first line, moderate to severe. Can also use it first line, mild. The others in the conventional class Hydroxychloroquine, the sulfasalazine, or the leflunomide. Those are the two in the middle, usually mild disease, or you can add it on. You can add it on the methotrexate. Although that ACR guideline showed you it's an option, but more preferable is probably to move to a newer agent, to move into a biological, or lastly, if the biological is not working, move down to those targeted synthetics, the Janus kinase inhibitors. So ACR, as I mentioned, recommends the initial monotherapy. One of these agents, methotrexate, is preferred in symptomatic, early, and any DMARD naive patients, meaning they haven't had a DMARD or never been on one. So specifically, methotrexate in that conventional class or traditional DMARD class can be given oral or through IV. What does it do? It's a dihydrofolate reductase inhibitor. So it's going to prevent the synthesis of reduced folates that are required for purine synthesis. So that makes it interfere with DNA synthesis and cellular replication. Basically inhibits fast-growing cells, which is happening in that autoimmune response in the joint, in the synovium, and at the cartilage. So ultimately that leads to decreased lymphocyte proliferation and immunosuppression with its anti-inflammatory effects. Because it prevents the synthesis of reduced folates, you've got to give folate when you give methotrexate, because it's reducing folate. So you got to add it back in. Because what happens if you have decreased folate? A big one is going to be those ulcers, aphthous ulcers in the mouth, right? In the mucosa, GI inflammation. So you want to add in folate, because you can also get the anemia, right, from decreased folic acid. So giving methotrexate means you're also giving folate. It's the preferred, most commonly used DMARD. Can be used monotherapy in mild to severe, or as you move up in that scale, you can combine it with other things. It's dosed once a week. The PANTS really hits that for some reason. It's once a week, right? Once a week. Because if folks start taking it once a day, then you're going to have all the side effects that we're about to talk about. Usually going to see a response in a month or so, 3 to 6 weeks. 25 milligrams a week is your max on this medication, on methotrexate, because if you go above 15, it's not bioavailable, so it's not doing anything, and you're getting increased risk of the side effects, which we're going to discuss. And as I mentioned, add folic acid to reduce those side effects of decreased folate. If they can't respond to folic acid, there is a medication, folinic acid, you can use as well, which, just FYI, it's also used as a methotrexate overdose antidote if you got too much on board. If that patient starts taking methotrexate once a day versus once a week, we can put the folinic acid in as an antidote to the methotrexate. Adverse effects. GI is most common, that mucosal ulcerations and inflammation. So know that means that is what stomatitis is mucosal ulceration inflammation, and that's from the decreased folate, the decreased folic acid. Diarrhea, nausea, vomiting, gastric irritation. When we start to use the methotrexate chronically, we can have decrease in white blood cell proliferation. So the bone marrow can get suppressed. Liver toxicity is an adverse effect, and there's also a specific pneumonia. So some pneumonia-like syndrome that can be caused from methotrexate. And at high long-term dosage can cause increased incidence of cancer, of malignancy, which is interesting because it's used as chemotherapy for cancer at very high doses. But long-term treatment can cause increased malignancy. Drug interactions. NSAIDs, important to know. Your antibiotic, SMX, TMP, sulfamethoxazole, is also, or Bactrim, a drug interaction, and probenecid. So we're going to talk about probenecid during gout. That's mostly what it's used for. So because of those common side effects we're going to talk about on the next slide, the monitoring that must be done. If it's taken with the Bactrim, it's going to increase the chance of methotrexate toxicity, those adverse effects, mainly being GI. And then if you have any kind of renal issues, it's contraindicated. You need to know the PANTS loves to ask about methotrexate in pregnancy. If a patient is pregnant and you see methotrexate, that's wrong. You should not, no one pregnant should be on methotrexate. Teratogenic, horrible on the fetus, methotrexate does not go with pregnancy. If you are going to try to conceive, your patient's going to try to conceive and they've been on methotrexate, you got to discontinue it for at least one menstrual cycle for women and 3 months for men, because it can also affect men's spermatozoa. And as I said, you got to be precautioned with renal or hepatic issues and alcoholics, because it is liver toxic. So those folks, if you have an alcoholic on methotrexate, then that's a routine screening of the liver functions. May decrease response to immunizations. We're going to talk about the biologics, which biologics you do not give live immunizations for. For the methotrexate, it may decrease your response to it. And have to know that for biologic agents, any of the biologic, so the TNFAs and the non-TNFAs, no live vaccines, because they decrease your immunity and the immune response. So a live vaccine could actually cause an infection in that patient. So here's your chart. We talked at length about methotrexate. These are the other conventional DMARDs, or traditional, if you will. There's a couple of things to know. So the first one on the list, lefonamide. It's an alternative methotrexate. Still have to monitor the LFTs. Know that it is also teratogenic. The monitoring is pretty much the same for all of them. Although on the hydroxychloroquine, you need to know that vision changes is a big adverse drug response. So they have to have frequent eye exams. Chronic therapy causes retinal toxicity. That's what I need you to know about the hydroxychloroquine. Something interesting about the sulfasalazine. We talk about it in GI and using another autoimmune disease, IBD, but you've probably heard of it before because it has a unique adverse, it's not really adverse, but it's a non-harmful discoloration of the urine and tears and sweat, right? Orange urine, tears, and sweat is, and for some reason the board likes to ask about it. So know that sulfasalazine causes that unique discoloration. Don't give it to G6PD deficient patients either. The big one on the on this list, though, is knowing about the retinal toxicity with the conventional DMARD hydroxychloroquine. Sulfasalazine and hydroxychloroquine can be used in pregnancy, but not the lefonamide. Yes, ma'am.
So how common is this G6PD?
I don't know what the numbers are, often enough that every single person that joins the military has to be screened for it. So I don't know. I'd have to look up. I don't have it on top of my head. I'll ask Heem. I'll ask Mr. Rakowski. But I'm not sure about the prevalence of G6PD deficiency. But for every one of us, or every one of you and everyone else in the service, you're screened for it. But I don't know by population. Worldwide and U.S., I'm not sure. Good question. I'd have to look it up too.
I'm assuming you're on the military personnel.
Yeah, I'm not. Yeah, probably not. So in the other room, someone Google machined it, I think. 4 to 7% of the U.S. population has G6PD deficiency. That was the question in the room. Thumbs up that y'all heard what I just said. All right. All right. Let's take a break, 10 minutes, and we'll come back and finish up the DMARDs and then knock out gout and get you on your way. To a slide here just to make sure we're all on the same page. So if you look at this chart, this is what we're working through, basically that bottom green box. And I mentioned to you, methotrexate always, right? Methotrexate always, if tolerable for RA. Then you can try methotrexate with one of the other traditional, right? The hydroxychloroquine, the sulfasalazine, or any of the ones in that class. But if they fail that, you keep methotrexate, and now look down. You go to a biologic, right? TNF inhibitor and methotrexate. Okay, they didn't do well with the TNF inhibitor with methotrexate. What stays constant? Methotrexate. So now I drop the TNF inhibitor and I try the non-TNF inhibitor. Both biologics, but and that's the order that you should do it, right? TNF inhibitor first, and it's the most, the evidence shows has the most efficacy. That doesn't work, then go with the non-TNF biologic with the methotrexate. That doesn't work, methotrexate, constant denominator here, right? And then we try it with those new targeted synthetics, the JAK inhibitors. At this point, we've only really talked about the methotrexate and the CS-DMARDs. Now we're going to talk about that next level, which is the biologics, and then finally the targeted synthetics or the JAK inhibitors. So just make sure we're all tracking. Hopefully I can remember where I was. Biologics. So if they don't respond to conventional DMARDs, now we move to the biologics, which has two subclasses, right? Basically, this class are proteins that are engineered to target specific components of the immune system. So on the slide, you can see all the different things that are happening with the immune response. These are just going to have action at one of those response levels. We're not going to get so deep down into weeds about where it's acting on each one. What you need to know about them mainly are in their names, right? All biologics, either the TNF alphas or the non-TNF alphas, all of them, as I mentioned earlier, are going to decrease your immunity response. So increased risk of infection. All the meds in the TNF-A alpha and the non-TNF-A alpha, so all of the biologics, no live vaccines. You need to know that absolutely. And then the mechanism of action for the biologicals, basically it's blocking the pro-inflammatory cytokines, either at TNF-A alpha, so that would be the TNF-A alpha class, or if it's the non-TNF-A, then it's going to be working at interleukin or binding on target receptors and T cells. Basically, that's going to prevent the co-stimulation that activate T cells. You don't need to be that down in the weeds with it. I need you to just understand the difference between the biologics and then the TNF alpha class versus the non-TNF-A alpha class. And then as I did with the conventionals, I'll point out kind of the special things you need to be aware of. Combined with methotrexate, most beneficial, just like we talked about on the flow chart from the ACR. Insufficient evidence of harm to the fetus in pregnancy. So methotrexate's the one I said absolutely no go with pregnancy. And there was another one right below it, or the first one on that chart, much like methotrexate, teratogenic. But for all the biologic, insufficient evidence. So that's got to be benefit versus risk and patient dependent. A discussion between room and the obstetrician, right? So the biologics TNF-A alpha inhibitors. So TNF-A alpha basically is just a pro-inflammatory cytokine. So you're going to inhibit that. These drugs are going to block that pro-inflammatory cytokine, TNF alpha, thus it's a TNF alpha inhibitor. So very effective. You've probably heard of some of these medications. They advertise them like every 5 minutes during any sporting game, right? We've all heard of Humira, Enbrel, Remicade, and they always say the same thing. So you shouldn't have to really study that. You know, notify your doctor if you have hepatitis B or C. Do not get live vaccines. It's all in there, like in 1 minute. rapidly said, but yeah, very common class, very effective. You'll see the difference there. I just need you to know that if you know, kind of the easy Mercer way is I can look and see that there is a suffix on all of the biologics, whether it's TNFA alpha or non-TNFA alpha. It's either a CEP or a MAB, right? So I kind of, if I can pick out patterns, I try to do that. But there are MABs and CEPs in TNFA alphas and non-TNFA alphas, but as a whole, those two suffixes are in the biologics. Did I make sense with what I just said? Okay. All right. So all TNFA alphas cause increased lymphoproliferative changes and other cancers. So they can affect the bone marrow and other cancers in both kiddos and adults. So that's the black box warning for all of the biologics that are in the TNFA alpha class. All right, moving on. Here's the chart. When you look at this one on the TNFA alpha inhibitors, as I said, you see the constant suffixes there, with the exception of etanercept, they're all MABs. And if you look at that top of the chart, the efficacy, ACR20 response rate, just FYI, what does that mean? It indicates 20% improvement in RA symptoms based on drawing off some fluid and looking at joint counts of inflammatory markers. There's other criteria for it, but just know that ACR20 is measuring the effectiveness of the drug in RA. It's measuring a 20% improvement. You don't need to know that. That's just FYI because it's on the slide. So I like to always try to explain something that may be new material that you're going to be looking at and going, well, what does that mean? So basically effectiveness for the drug in RA. The ADRs, they're the same across the board. I mentioned the big ones. They're in bold, right? Risk of infection, malignancy, Hep B, and TB reactivation. And then the monitoring, TB screening, Hep B, C, as we mentioned, for all biologics. CBC and LFTs. And then if a patient has any signs of infection while on a biologic, go directly back to the provider and discuss, right? Or you as a primary care PA probably going to be prescribing biologic DMARDs. Probably not, right? However, you will have patients that are on biologic DMARDs, and so you need to be able to understand what's coming back in those consult notes or when to make consults to room, right? So now we're talking the non-TNFA modulators. So as the chart shows, methotrexate stays a constant. First we go into the biologic class, starting with the TNFA inhibitors. They failed that? Well, let's talk about the non-TNFA modulators. And they all, as you see, they all still have our CEPT and UMAB as a suffix, so we can pick them out of a lineup. And each has this unique profile. I do not need you to remember and memorize where each one is exerting its mechanism of action. We know it's not at TNFA alpha, right? That's what I need you to be able to pull out of it, because it's a non-TNFA alpha modulator. And once again, the catch-all biologics, all in that class, increase infection and do not initiate if the patient has an infection. So the chart for your non-TNFA modulators. So pay attention to the bold black box warning with the B cell modulator, rituximab, tumor lysis syndrome, and fatal infusion reactions. The last two on the list there, make sure you look at the comments for avoiding in patients for high risk for GI perforation. What would be high risk for GI perforation? Okay, so peptic ulcer disease, yeah. IBD, as we mentioned, right? If you got chronic inflammation somewhere in the gut, right? Autoimmune disease. diverticulitis, so some kind of structural problem going on somewhere in the GI tract, puts you at higher risk for perf. Like I said, be able to pick them out of a lineup. I'm not going to dig deep on the actions, mechanisms, and where the non-TNFAs insert their action, their mechanism of action. But definitely know the black box warning for the B cell modulator, rituximab, as tumor lysis syndrome. So now we get into the JAK inhibitors. These are oral. I don't know if I mentioned, but all of the biologics are going to be injected, right? They're injectables. So I'll point that out. But the JAK inhibitors are Janus kinase inhibits that enzyme, Janus kinase, and these are small molecules. They're oral, not biologics. Not biologics. People often get confused because we go from the conventional synthetics, then into biologics, and we got the TNFA and the non-TNFA, and then we go to the JAK inhibitors. Now we're out of biologics, right? There's the only two classes of the biologics, or the TNF alpha and the non-TNFA alpha. I'm sorry, the non-TNF alpha. So now we're looking at an oral medication, not a biologic. It does kind of the same thing. It interrupts cytokine signaling, but intercellularly, so inside the cell. They're as effective as biologics, and as we've shown on the flow chart, you're going to use them when patients are not responding to that combination of methotrexate all the way down from the TNFA inhibitors, non-TNFA inhibitors, keeping methotrexate as the constant. Now we move into the JAK inhibitors. So the big thing to know here, this is the first time we've seen this black box warning in this class. I would know the star at the bottom of the slide that there's a black box warning for thrombosis. Infection's been there, right? Infection's kind of been there with all of our, with the biologics and even methotrexate because it's immunosuppressive, so the conventional synthetics. But now we got this cardiovascular risk and risk of thrombosis. That's one of these does not look like the other, so I would make sure I knew it. Right? Black box warning for the target synthetic DMARDs oral JAK inhibitors, that they have that black box warning for thrombosis. So pulmonary embolism, blood clots, kind of a big deal. Now we're moving into our last topic, gout. So basically a disease spectrum that includes hyperuricemia. So increased uric acid in the blood, right? You're going to hear that it's rare before age 30. It's becoming very more prevalent in younger populations. So if someone, when we talk about the signs and symptoms, if someone comes in with a peripheral red, hot, swollen joint, wake up at night with the pain, don't rule it out, right? So classically, rare before 30. Average age of the first attack is 48. More men than women. So basically you have attacks of acute arthritis where you have monosodium urate crystals in the leukocytes in the synovial fluid. When you get into ortho, they're going to talk about, you can do a joint aspiration and you look at it and what its biofluorescence is and what color it is. You don't need to know that for this class. We're not diagnosing it. I'm going to tell you it's gout. And gout is from recurrent attacks of urate crystals in the synovium. So monosodium urate crystals are in the tissue. That is the definition of tophi. You need to know that. When you get those monosodium urate crystals from increased uric acid in the blood, then when those crystals start to form into the joints, that's called tophi. You can also develop interstitial renal disease from it, and you can get some stones in the kidneys from that increased levels of uric acid leading to a deposition of the urate crystals in the tissue. Hyperuricemia is basically an imbalance of making too much or the kidney's not getting rid of enough. The latter, the kidney not excreting enough, is more likely the cause. Higher incidence of that being the issue versus overproduction. So an inability to excrete the uric acid is through renal elimination. That's the biggest cause of gout or the tophi. You can have hyperuricemia without having gout, i.e. your uric acid can be elevated, but you don't get tophi and you don't get joint swelling, you don't have pain, you don't have issues from a gout flare. So you can have hyperuricemia without the diagnosis of gout. What is uric acid that makes these little crystals that are deposited as tophi into small joints? That is the breakdown of purines. And we'll see that pathway as we talk about the medications that we use to prevent hyperuricemia. I can tell you that patients with gout are in extreme, excruciating pain. They're going to come in some serious pain when they have a gout flare. And they are freaked out if it's the first one they've ever had, because a lot of times it starts at night. So we'll talk on the next couple of slides that the big toe, the first MTP, is a common site for gout. And so their toe touches the sheet while they're sleeping, and they, wake up like they've had their, toe set on fire. And usually happens at night. Not always, but they're in a lot of pain, and it's acute. So here's the pathophys. You can see that purine pathway on the right, adenosine, inosine, and we're not worried about the enzymes there. But when we get from xanthine to uric acid, xanthine oxidase is what causes that reaction. And then it's either excreted, because uric acid it's bio-neutral, doesn't do anything for us. So it's excreted, and some of it through urate oxidase action is converted to allantoin. So no physiological purpose for uric acid. You need to know that that lab level. So hyperuricemia, serum urate level greater than 6.8. Does a serum urate level of 6.9 mean that I have gout? No. I have to have the tophi, the signs and symptoms. You can have an elevated level of serum urate without having gouty tophi disease or being diagnosed with gout. And in fact, some folks have gout, but with normal serum urate levels. So what makes the difference is if you're having signs and symptoms and tophi, exactly. Because even if they have a normal serum urate, but they have the tophi, it's a gout, right? It's gout. And vice versa. If they have elevated serum urate, but no tophi, not gout, just hyper elevated serum urate. So what are the predisposing factors? They used to call gout the disease of rich and kings, right? And you can see that by the dietary ingestations that cause it. Purine-rich foods, meat, seafood, red meat and seafood, wine, fatty foods, alcohol, sugar-sweetened soft drinks for the modern kings, right? And high fructose foods. But just think, as I said, it used to be, actually, if you read back in history, it used to be like a badge of honor, right? Oh, I have gout. I'm great. I'm upper class because I got gout. I can eat like a king. All right. So alcohol does stimulate uric acid production. Diet really only accounts for 1 milligram per deciliter of serum uric acid, so there might be some genetic predisposition to those increased levels of those the foods of kings, but it's often associated with that. You'll hear red wine, red meat, seafood is a big player. You can have some medical conditions that predispose you to gout, the ones that you would think of, usually of overindulgence, not always, but obesity, diabetes, hypertension, dyslipidemia, kidney disease. As we mentioned, that the uric acid is supposed to be excreted from the body through the kidneys. So if the kidneys ain't working too great, well, you can get a backup of the uric acid, i.e. leading to tophi and gout. There are some conversion genetic disorders. You don't need to be aware of them. They're pretty rare, but they're at the third bullet. So there are some genetic predispositions to being able to either having increased levels of purines in your blood or not being able to excrete them. That's more for your knowledge. I do need you to know the last bullet. Must know, got to know, on every board I've ever taken, it will be there. That loop and thiazide diuretics worsen gout. How do they do that? So loops and thiazides are going to reduce the renal excretion of the uric acid, and then the blood's already going to be becoming more concentrated. So then your levels of urate are higher in the blood, right? And when you have that volume depletion, increasing the blood concentration of the serum uric acid, then that's when you're going to develop the gout. So know forever and always that for gout, loop and thiazide diuretics worsen it. And oh, by the way, I can tell you now, it will be on your test in block 4 too. So you're going to see it forever. Not that exact question, but knowing that concept. So acute gouty arthritis, rapid onset, as I mentioned, go to bed, okay, wake up, I'm not doing good at all. So when you have that most common joint, the first MTP, the big toe, right? Podagra is you'll see that in exam stems, so make sure you understand, just like you understand tophi, that you understand podagra, because if you miss those two terms and don't know what they mean, then you're setting yourself up for failure for understanding the question being related to gout. So tophi at the first metatarsophalangeal junction has its own special name, podagra, because it's so common there. Most common manifestation on the slide. You can also have it at the other peripheral joints. You can have it at the ankle, at the foot, the knee as well. You can, attacks can be preceded by physical stress, but they usually come on at night, as I said, while the patient's sleeping. Lab findings, if you see uric acid above 7.5, about 95% of the cases of gout. And as I mentioned, in up to 25% of cases of gout, they can have a single uric acid reading that is normal. So we said 6.8 and above is abnormal. So 95% of the cases is elevated above 7.5 milligrams per deciliter. But if you don't have tophi and you have elevated levels, you don't have the gout. Not yet. So here's some pictures of what gout tophi manifestations are. The ear helix you can see there. You can see on the distal finger that you can see the podagra there on the top left. And then I guess the toe next to it got involved on the right slide versus the most common podagra. And then there's an x-ray showing it at the wrist. The tophi. Those urate crystals deposited just beneath the skin in the joint. So the goals of treatment, a little different from the stuff we talked about before. So with gout, as I mentioned, you go to bed feeling okay or you're feeling normal, you have acute pain. So the first thing we're going to do is try to get some pharmacotherapy on board for the acute attack, pain control. Once we get that controlled, then we're going to talk about, do we need to, based on if the patient has another episode and another episode. If we start having more than 2 a year, then we get into the medication classes that will lower their serum uric acid, right? We want to lower that if they're having chronic bouts. We don't always go to urate lowering therapy, but we'll give you the criteria. But we always first get them out of pain, right? So when we do have an attack with treating, and we'll go to the next slide, we'll talk about how. And here's a preview of coming attractions, the same way we treat pain for the most part in all of the disease processes with NSAIDs, but we got another new drug to learn about today. We want to get that serum urate below 6, and you need to know that if there's tophi present, when they have that acute gout attack, if there are tophi present, then may consider going all the way down to 5. Getting the serum urate target below 5. Improving the signs and symptoms. Always 6, maybe 5 if tophi are present. So goals, get them out of the acute pain, control the pain and inflammation, see how often it happens again, and then consider lowering their serum urate levels. So acute flares, NSAIDs, colchicine, and steroids. Number 1 and number 3, we've already talked about how anti-inflammatories and pain modulations, but colchicine is almost specific to gout. You'll see it in the treatment guidelines for pericarditis as well. It's not an NSAID, and we'll talk about it in depth since it's usually the go-to agent for an acute gout flare. If it's mild, and we're going to talk about this at length, this is just a preview on the chart there to your right. If it's mild, we can talk about monotherapy with one of those agents. We can start combining agents, as you see on the chart, the second row of light blue boxes. We can start combining those 3 medications, NSAIDs with colchicine or NSAIDs with glucocorticoids, whether that be oral or into the joint with an intra-articular injection like we discussed earlier, or intra-articular steroids, or colchicine and a corticosteroid. So basically any combination of the acute flare pain treatment modalities on the top left can be combined if it's severe pain, or multiple joints involved, not just one, but multiple spots for your patient, multiple joints affected. And then based on the criteria we're going to define, there's 3 different classes of medications for chronic lowering of the serum urate. So urate lowering therapy, and then we'll talk about each of those and the indications, and then why we use some drugs over others. So this is just a flow chart of all that. You can refer back to it. Not as to confuse you, I'm going to go through the steps on the slides, but you can come back to this. Basically, it just flows through the outcomes of that acute flare, and then when are we going to move into chronic urate lowering therapy. And you can use this as a study guide, but do want to point out on the bottom right, inadequate response when we talk about medications for gout. Inadequate response would be less than 20% improvement in pain within 24 hours, or less than 50% improvement at 24 hours. And obviously that's talking about acute gout flare. Whether it be the first time or the 100th time, the response to medication is how we define it improved or didn't. Yes, sir? Yes, pain scale. Yeah, so subjective, yeah. So how do we manage it? As I mentioned, mild to moderate, we're going to use NSAIDs, right? Or colchicine. No preference of one or the other. Oral corticosteroids is also an option. We are in the recommendations, there is a recommendation for topical ice as an adjunct because they have a red, hot, swollen joint, so ice should help. No preference for the mild to moderate, so only one joint, moderate pain, you choose one, NSAIDs, colchicine, based on comorbidities, right? Or oral steroids. So if the patient can't take NSAIDs, and move to one of the other drugs. If they can't take that drug, then choose one of the others. So no preference for any of the 3. Looking at patient presentation, comorbidities, and any previous treatment to acute flares and what worked for them. If you haven't gone to ULT yet, or urate lowering therapy. If your patient has all of those GI contraindications, then use a COX-2. Slide says celecoxib or Celebrex, but a COX-2, that is gut protective, or more gut protective than a COX-1 combo, COX-1 to COX-2. So severe pain, then we're going to look at combination therapy, and I mentioned it on the last slide, right? But if we're going to use colchicine, I gave you in the pre-check on learning, how soon do we have to get colchicine on board? Within 36 hours or it's not effective. So keep that in mind. I would know that forever. Colchicine is only effective within the first 36 hours. So what it does is, and we'll talk about on the next slide, but basically it inhibits neutrophil migration to the area of inflammation. Not an NSAID. And it has some specific dosing. But the take-home point is combination therapy for severe pain or multiple joints. I will tell you We're going to talk about colchicine side effects. They're abdominal, like it's abdominal pain, diarrhea, and now if you're using a non-selective NSAID, what is its common side effects? GI, right? So colchicine and NSAIDs have caution. I have seen patients have some severe diarrhea, abdominal pain, and some GI upset with those two combined. Solution, if I'm going to do that, I'm giving a PPI. If I'm going to combine anything in that list, I'm probably starting them on a PPI, gut protective, right? I think it's a good practice. Might not see that on the pants. You may. I think they do. I think they do mention in the the PAEA PPI for combining the NSAIDs and corticosteroids, but I would get in the habit of a PPI for any NSAIDs, high dose that I'm giving, or a combination with something else that has abdominal side effects. So if you're going to combine these two, that's just a personal preference. You won't be on your test, but I would think of a PPI if I was going to combine colchicine with an NSAID or a colchicine with a steroid or any of those combinations, right? Because all three medications that are our choices for the acute pain relief can have GI effects. And when you combine them, it's synergistic, as it says in bold on the slide. So won't be on your test, but I would give a PPI for gut protection. And then you're going to keep them on the acute treatment, whether that be single drug or combination, until the acute attack resolves. So you want to get it on board within 24 hours. NSAIDs, colchicine, appropriate first line combination. So we're just kind of repeating what we said on the other slide. And there's your take-home test question. That colchicine has to be within the first 36 hours of an acute attack. Another must-know forever. If your patient is already on urate lowering therapy, which we haven't discussed yet, but when we say, hey, they have more than 2 acute gout attacks a year, then we're going to start them more than likely on a urate lowering therapy. So you do not start urate lowering therapy during an acute attack. You don't go, oh, this is gout, here's your NSAIDs, it's severe, here's your NSAIDs and colchicine, and oh, by the way, let's go ahead and start you on a ULT, urate lowering therapy. The reason is when you get that ULT lowering therapy, there's 3 different classes. We're gonna get into them, but all of them disrupt the uric acid kind of depositions in the joints. So yeah, you're having the acute gout because of the TO5 maybe at your first MTP, but you're going to have other serum uric acid crystals in your body somewhere. So when you throw in ULT, your body is going to see that decreased level and it's going to mess up the metabolism and it can worsen the gout attack. So don't start ULT during an acute attack. Vice versa is also true, which is a common attraction. If you're starting ULT, I just said it can worsen the signs and symptoms of an acute attack. So guess what you start ULT with? Combination of ULT and one of these drugs as low dose. So the opposite applies. Because ULT tends to precipitate worsening of a gout attack, you start on low dose colchicine, steroids, or NSAIDs. However, it's an acute attack, then you start them on colchicine, steroids, or NSAIDs, or a combination, but don't start ULT. And the third option, if they're already on ULT and have an acute attack, keep them on it. Don't change it. Everybody tracking those 3 options I just gave you, right? New attack, not on ULT, don't start it. They get better. If they have more than 2 per year, consider putting them on ULT, 2 acute attacks. If you're going to start ULT, get a steroid colchicine or a steroid as a prophylactic treatment. It's going to be a low dose, and we'll talk about it. You don't need to know the dosage, but low dose. So you're going to start the ULT with one of those prophylaxis medications on board because the ULT can worsen the attack. And if they have an acute attack while they're on ULT, keep them on the ULT and then treat the acute attack just like you do for every acute attack, either a single of the 3 or a combination of the 3. It's that easy. We can take the test right now. Everybody's ready. All right. Acute flare. First line, if no contraindications, naproxen. We've talked about the NSAIDs at length. So indomethacin is kind of the go-to. It has an FDA approval, that and Solendac, which is Clinaril. You don't hear of that one too often, but they're both FDA approved, but it's really any NSAID. Acute attack of gout, initiate with maximum dose and continue for 24 hours after complete resolution. Then you taper it over 2 to 3 days. Indomethacin and naproxen considered drugs of choice. We talked about COX-2s, so you guys understand to use those if there's a risk of GI bleeds. Now we're going to talk about colchicine, which is that other option for acute flare or acute attack. What does it do? It inhibits neutrophil microtubules. At the end, it inhibits the migration of neutrophils that mediate the gout symptoms. So we use it for a treatment of gout flares. And once again, there's that, must be used within 36 hours. There is a special dosing. We don't often test dosing in Pharm. I do need you to know for the PANTS though, that the dosing of colchicine within 36 hours, and then it's 2 tabs at the first sign of the flare, followed by 0.6 1 hour later, and then either 0.6 once or twice daily until attack resolves. But what I need you to know is that it's 1.2 milligrams at the first sign of the flare, so 2 tabs, and then you're going to go to 0.6. You stop it if patients start getting those GI side effects, right? The nausea, vomiting, or severe stomach pain. Do not repeat the colchicine course more than every 2 weeks because it can accumulate. And then, as I said, for prophylaxis, when you're going to start urate lowering therapy, it's a maximum dose of 1.2 milligrams. I'm not going to ask you that, but we'll just say for all of the prophylaxis treatments, when you're going to start ULT, it's low dose, either NSAIDs, colchicine, or steroids. Colchicine, caution in renal and liver issues, so you have renal dosing considerations. It has a significant drug-on-drug interactions with those CYP3A4 and P-glycoproteins. You've been testing on it, so I'm not going to test you on it. You should know what those are by now, but as a reminder, those are your macrolide antibiotics are a big player, the azole antifungals, and statins are a big one there. So drug-on-drug interactions with CYP3A4 metabolic drugs. Adverse effect, already mentioned, abdominal is a big one. 80% of patients. Some myopathy, a higher rate if there's statins. And then bone marrow suppression in less than 1% of patients. So acute gout pharmacology, steroids, we've already talked about them. Same as you would for OA, right? There's nothing different on this slide than we haven't talked about with the oral or the intra-articular. Then we get into the urate lowering therapy or chronic gout suppression. So basically, more than twice a year, you're having these acute flares. We're going to lower the urate level through chronic suppression with medications in one of these 3 classes. Either xanthine oxidase inhibitors, allopurinol is your first line. The other XOI, or xanthine oxidase inhibitor, is febuxostat, and it has a cardiovascular risk warning. And then there's uricosuric agents. Basically, what do? You pee out the uric acid, right, to lower levels, and that's the 2 players there. And then finally is your IV option, uricase, and we're going to hit each one of these briefly. And there's your star that I've already mentioned. Do not start urate lowering therapy with any of these 3 drug classes during an acute flare, but do not stop them if they're already on them during an acute flare. So when do we give ULT? So if there's tophi present when they present, 2 or more attacks per year, as I mentioned earlier, chronic kidney disease, or previous kidney stones. Those are your indications for ULT. So be familiar with those. First line is your allopurinol or febuxostat, so that xanthine oxidase inhibitors. and we're going to show you that reaction here. So basically, and I think actually I already did, so we're going to show you that's an enzyme that's being inhibited, so you can't make uric acid. And then if you cannot use one of the XOIs, if it's contraindicated or it didn't work for urate therapy, we're going to go to a uricosuric, i.e. through, it's going to increase your excretion of uric acid. And then finally, the uricase, which is an actual enzyme that converts uric acid to another metabolite in the body. And that's an IV option for severe. So the pegloticase is for severe refractory. So here's the XOIs, allopurinol and the febuxostat being the representative class. Allopurinol is your first line. You see xanthine oxidase with the red line under it. Basically, its action is blocking the conversion of xanthine to uric acid, the red arrow. So you're not making uric acid. So that's going to lower your uric acid levels. Because the xanthine oxidase is what converts it into uric acid. And as I mentioned earlier, we either excrete it through the kidneys, and 2/3 of that's renal, 1/3 of it's GI. You don't need to know that. But you just need to know that the XOIs inhibit the xanthine oxidase inhibitor enzyme, so it decreases the making of uric acid. It blocks the making of it from xanthine. So we mentioned that because of the serum uric acid levels with ULT, any ULT, any of the three classes, so you do prophylaxis. Low dose, one of those three medications, right? One of those classes, NSAIDs, colchicine, or steroids. So you do that when you start ULT, based on one of those 4 or 5 indications for ULT that I mentioned. Common adverse effects for this class. You need to know that they can cause Stevens-Johnson syndrome and TEN. Have y'all had Stevens-Johnson syndrome and TEN? Bad news, right? Bad news. So that is those changes, blisters, sores, large area of skin reactions, peeling skins, sores, swelling of mucous membranes, ultimately can be fatal. So if you've had it, I won't belabor the point, but that is a common adverse effect for this class. And then for the febuxostat, that has that CV, increase of cardiovascular event warnings. Black box warning for increased risk of cardiovascular death. Allopurinol remains our first choice. Rare but serious side effects of that Stevens-Johnson's and TEN. So it's a trade-off, right? Cardiovascular or SGS or TEN. Allopurinol remains the first line. And as I mentioned, inhibits that enzyme. So you're not making uric acid. This just compares the two, doesn't change that allopurinol is first line out of this class, of the XOIs. And then down below is the allopurinol hypersensitive syndrome that's causing Stevens-Johnson's and TEN, which most SGS and TEN is caused by medications. So we move into the uricosuric agents. So these agents, as are in the name, help you excrete uric acid. Losartan and fenofibrate are off-label. You need to just be aware of that. I'm not going to test you on it, but off-label uricosuric agents, losartan and fenofibrate. You need to know about the probenecid, right? So their second line basically increase the renal excretion of uric acid. So if they increase excretion, what would be a contraindication or make these drugs ineffective? Decrease renal function, right? If your kidneys aren't functioning and these medications are based on increasing the excretion through the kidneys, then they're not going to work very well. So creatinine clearance is going to come up, right? Normal 88 to 150, a little bit different between males and females. But if you start seeing things below 60, like 60 or 50, any med that's excreted through the kidneys is probably not going to be working well. And the mechanism of action is that probenecid is a weak organic acid, so it's going to promote renal clearance by inhibiting the urate anion exchangers that mediate urate reabsorption. In other words, it's affecting that channel, so they're not being absorbed back into the system, and they're going out with the urine. You'll also see probenecid used to reduce the excretion of some antibiotics, the beta-lactams. So basically, it keeps the antibiotics in the system longer. And then other meds can also, there can be reduced excretion, so you have to be careful, like NSAIDs. So if you're putting probenecid on, then NSAIDs are hanging around longer, so you can have increased side effects. Now, it's positive when you use it for the antibiotics because it keeps the antibiotic in the system longer. So we don't need to know the dosage, but basically just know probenecid, the uricosuric agent alternative to the XOIs. If they don't work, if there's a contraindication, or it's not tolerated. So we mentioned of all the ULTs, precipitation of gouty arthritis is a concern when you start it. GI, an issue again, and you can have, through probenecid, you can have uric acid stone formation. So don't give it to patients with uric acid crystals, or you can precipitate stones. So there's a lot of drug interactions, numerous interactions with renal clear medications, and then salicylates reduce or render it ineffective. So if you give aspirin, it's not going to work if the patient's on aspirin. And then finally, the pegloticase or the Cretexa. This is IV. When you start seeing IV, where's the patient? In the hospital, right? So this has failed everything else. Basically, where the red circle is, so on this chart, all the ULTs are pointed out, right? If you go back and look, the XOIs at the xanthine oxidase, and then now over at the urate oxidase, if you're giving that, that's what pegloticase is. You're converting the uric acid to something else, the allantoin. Severe gout, refractory, or intolerant to traditional urate-lowering therapy options. Interestingly enough, here, give it with methotrexate. It's given with methotrexate, which means it's going to be given with folic acid, just like when you give methotrexate for RA, right? And then the adverse effects, same for all ULTs, gout flares. Infusion reactions, so it's IV. So the infusion reactions can be called bruising, urticaria, sore throat, chest discomfort, so all those things from getting the IV infusion, or anaphylaxis. G6PD again, or if they're on another ULT, those are the two contraindications. Prophylaxis we talked about. The key is starting ULT, start a low dose, one of the three. NSAIDs, colchicine, or steroids. That's all that chart is saying. So for prophylaxis, your options, as I mentioned, low dose colchicine, low dose NSAID, give a PPI, it's on this slide, to prohibit those GI side effects or peptic ulcer formation. And then an alternative are the oral corticosteroids. That's your last line. So basically, if you can't do the NSAIDs or colchicine, get them on prophylaxis. When you're starting one of the three choices for ULT, usually the XOI first. Use the corticosteroids last as a prophylaxis if you can't do low-dose colchicine or NSAIDs. And then basically there's some timing. You're going to keep them on the prophylaxis based on whether they have no tophi for 3 months or a minimum of 6 months if they have tophi. That's more clinical case management. I won't ask you a specific question on that. All right, last couple of minutes here. So now we're going to see, compared to what did we know before, what do we know now? What are the drugs of choice for gout flares? Drugs of choice for gout flares. NSAIDs. Corticosteroids, I heard. What's the other one? New drug. Colchicine. There we go. True or false? DMARDs are the mainstay of RA and help with disease control. Absolutely slam dunk. Gout flares may be precipitated by what drug class? Got it. y'all are ready for, what is it, Friday? Next Friday is the test? All right, the memory jogs are there. And as always, start with the memory jogs. It'll get you mostly there, but then branch out. This isn't a lot of new material, so I'd focus on the new stuff. The big thing is knowing the goals in treatment for the different disease processes. NSAID, know the goals and how we get there. OA, the goals and how we get there. Gout, what are the goals and how do we get there? And then for RA, what are the goals and how do we get there? And it should be pretty straightforward. Memory jogs give you a good, strong foundation. You're all going to do well. Good luck, and then we'll chat next week.